Good afternoon. Welcome to Bariatric Friday. My name is Kemal Erkan. I'm the chairman of American Surgery Center. And I have Dr. Isaias Irgau with me. Dr. Irgau, how are you doing?
I'm doing great, Kemal. It's great to be back again on another Bariatric Friday. Happy Bariatric Friday.
Thank you. And we are going to actually start a new cycle with 3 new patients. As our format, it kind of goes through the same process, and then we are explaining this. So we choose to make it a little bit more, like put it in a perspective, so that way we have new patients, and then we are going to discuss why we are going to have certain procedures, and we're going to start with that, and then we'll have the entire process until they're ready for the surgery. So we are going to talk through them. So today we are going to discuss the bariatric surgery types and why and when we need different types of surgeries, and there are several different options. And so I'm going to ask Dr. Irgau to start. So just overall, Dr. Irgau, like if you were to give us the background on different bariatric surgeries, and then I'll bring the patients up one by one.
Absolutely. So essentially, weight loss surgery, which is also known as metabolic surgery, is aimed at weight reduction, but also at bringing about a healthy metabolism. Now, metabolism is the process whereby food is broken down and transformed into energy. Okay. And when the metabolism is not right, we can develop many illnesses. So by making the metabolism right, we're also treating many diseases related to a deranged metabolism, essentially, right? So we're treating obesity, but also we're treating type 2 diabetes, we're treating hypertension, we're treating sleep apnea, we're treating high cholesterol. In fact, we're also preventing future health problems as well as extending the lifespan of the person, right? So bariatric surgery from that point of view is really huge. It's not just reduction of weight, but also it's getting many health benefits. The procedures that we perform right now are procedures that have been refined over time. In fact, bariatric surgery happens to be one of the most studied areas of medicine over the years. And so we have achieved standards of safety and quality, but also refinement of procedures that led us to perform procedures now, even very complex procedures with very small incisions. It's called laparoscopic surgery. Very often the surgeries, particularly in places like ours, are performed as outpatient procedures where the person have the procedure done and they go home in the same day. The safety of these procedures right now is actually comparable to very common procedures like gallbladder surgery, like hysterectomy, or hip replacement surgery. And the fact that we're able to do it with laparoscopy also means that there is less pain with this surgery, that there is faster recovery, but also more importantly, there is much less complication when the surgery is performed in the way we do it right now.
All right. Well, thank you for that, Dr. Irgau. Now, patients do come to us with their mind, in some cases, their mind is kind of set, so I'm going to have this surgery.
Yep.
Because we see that all the time. So the issue for us is, well, that's not, that's not how we are going to approach this. We want to actually make sure that we give you the best knowledge of these procedures, but you'll get it from the person who knows this the best, not from what you read from Google or that you hear from other people, from TV programs and this, but the actual person who's going to operate this and who knows about this the most. So we want patients to come with open-minded approach, so that way we can help them the best. Now, how do you deal with those patients when they insist on certain procedures and you know that they are that's not the right one for them?
Yeah, well, fortunately, Kemal, the vast majority of patients are okay to have most of the procedures that we offer. In other words, absolute contraindication to a particular procedure is something which is not very common. So if a patient feels much more comfortable with one type of procedure, either, as you said, because of what they have read, or because what one family member of theirs had, or because they have seen something, some complication with a particular procedure on somebody that they know, in the vast majority of cases, we're actually able to accommodate that. Because as I said, these procedures are indicated when a person is suffering with morbid obesity and when the person has problems related to obesity. So the vast majority of patients will be fine with any of the procedures. Now, of course, a particular procedure may be really optimal in a certain situation. And of course, I try to explain that to the patients. But ultimately, I do want the patients to be comfortable with the choice of procedure. There are certain situations, of course, where a particular procedure may not be feasible for a patient. Okay, so for instance, let's take a patient who has severe heartburn, for instance, right? And I'm not talking about heartburn where you take Tums occasionally. I'm talking about heartburn, which is really very difficult to control. And that patient undergoes endoscopy, which is examination with a little camera of the food pipe. And then we find that there is actually severe irritation of the food pipe. In fact, changes of the food type to something called Barrett's esophagus. In which case, if the patient insists on having a sleeve gastrectomy, I will counsel them against that. In fact, the best procedure in that situation will actually be the gastric bypass procedure, right? On the other hand, let's say a patient comes in, they want the gastric bypass, but let's say this patient is on a number of medications that require fairly predictable absorption when they are ingested, right? Let's say, for instance, this person is taking medications for mental health, right? Where you really need them to take those medications and you want medications to be absorbed well. Well, that absorption of that medication sometimes can be interfered with if a patient has gastric bypass, which is where we have rerouting of the intestine, right? In which case, I would counsel that patient that the sleeve gastrectomy may be a better procedure for them, because with the sleeve gastrectomy, we are not rerouting the intestine. And therefore, their ability to take their medications and feel comfortable that their medications will actually enter their body without any problem are going to be much better with the sleeve gastrectomy than the gastric bypass. So definitely, on the one hand, I do want patients to come to us with good knowledge and background. I want them to really have done their research. Most importantly, I want them to really have tried to lose weight by themselves, not necessarily because I want them to go through some rite of passage, but because I want them to understand that the struggle to win against obesity should not just end with the procedure. The procedure is a tool, it's a very powerful tool, but I do want them to make important changes as well. So I want patients to come informed. I want patients to have with some knowledge, but I do want to work with them to make sure they understand clearly the purpose of the surgery, they understand clearly the implications of the surgery, and also the commitment that is needed for the surgery to be successful.
So you always have the better answers. Now, let's put this in perspective. I'm going to give you some background on each of these patients from the clinical side. So these patients are with fake names. They're real people. And our first one for this cycle is Denise.
Mm-hmm.
Denise is 32 years old.
Mm-hmm.
We got her blood work already.
Mm-hmm.
We had that from their primary care providers. Normally we do order them, but this time we had her A1C actually is 9.
Mm-hmm. Mm-hmm.
Her TSH is 1.5,
Mm-hmm.
and also her hemoglobin is 9.
Okay.
So A1C 9, TSH 1.5, hemoglobin 9. 32-year-old has sleep apnea.
Mm-hmm.
Well, we suspect that she has sleep apnea, so we sent her for the
Yep.
home sleep study. and she doesn't have heartburn, and yeah, she's 32 years old. So she comes to us for a lap band, and actually, this was one of the patients that we tried to reach out earlier than the consult to talk to them about the choices, and they wanted to be in the, they wanted to actually see the surgeon and then wanted to make their decision, but they're actually coming for a band. So
absolutely. So, and remind me, what was what's Denise body mass index BMI again?
Her BMI is 43. Of course,
okay.
Okay. I can give you.
Yeah. So I absolutely. So essentially, I am going to guess that Denise wants the gastric band because she feels it's the safest procedure of them, right?
One of her friends had it a long time ago, and then the friend was successful, and that's why she wanted.
Absolutely, absolutely. So with the gastric band, essentially what we are doing is we are placing a belt around the upper portion of the stomach. It's a device, and the gastric band works by really restricting how much a person can eat at a particular time, and by making them full early as well, right? Now, because the tightness that is caused by the band has to be individualized, the gastric band is adjustable. In other words, the person who has the band has to come to the office on, from time to time to have adjustments done, which is done through little injections through the skin to a little device that we call port to take fluid out or put fluid in, either to loosen the band or to tighten the band, right? But there is no cutting of the stomach. There is no cutting of the intestine. In fact, this device can be removed just as safely as it is implanted. And from many patients' point of view, this is actually a very good approach because they're having a procedure that is not one way. It's a procedure which is reversible, right? So that's it. But the question, of course, is going to be, is this going to be a procedure appropriate for this? Well, first of all, it is clear that there is no obvious contraindication to Denise having this procedure. But the question will be, is this an optimal procedure for her, right? Is this going to be the best procedure? Well, first of all, we have to think that, we want her to lose adequate amount of weight and keep it off, right? She does have diabetes. You mentioned that her A1C was 9, right? Yeah. And we want to make sure that there is appropriate improvement in her blood sugar as well. Can the gastric band do that? Yes, it can, right? Are there better procedures that could do this even more strongly? Yes, absolutely. So the gastric sleeve, for instance, can do that. And of course, the gastric bypass would be able to do that as well. The advantage of the gastric bypass would be that it is going to be very powerful in really having an impact on the blood sugar, right? But then we worry about the fact that she has a low hemoglobin. You mentioned that she has a hemoglobin of 9, which suggests that she has anemia. Now, a person who has gastric bypass can have worsening anemia because their ability to absorb the iron is decreased. So maybe the gastric bypass may be too much of a procedure for her, so the sleeve might be a better option. So at the end of the day, if Denise is set on having the gastric band, she can have the gastric band. There is no big contraindication, but the more optimal procedure might be the gastric sleeve. One area that is important to talk about, Kemal, is the fact that we're not doing as many gastric bands as we used to do in the past. And one of the reasons is because sometimes the quality of life with the gastric band cannot be as good as with the other procedures, in that there is no real predictability on whether they will be able to swallow something that they're eating. So they find themselves interrupting their meals very frequently, having problems with vomiting, having adjustments very frequently to deal with that. But also, we found that very often there may be problems related to the device itself that will require removal of the device as well. So,
no,
go ahead.
So I think we want to make sure that patients understand this really clearly. So with the way that the band works, our whole stomach is there. So if my BMI is 43 already, I have a pretty big stomach, right? So with 43 BMI, so we take that top part of it and then making it smaller, kind of like smaller pouch or smaller stomach, I guess. Yeah. So now, problem is there's nothing changing on that stomach, so that part with the eating habits that we have is able to just do what the rest of the stomach did before, then it can actually enlarge in time, especially with the high BMI. So that actually is one of the challenges with the band, and that's why maybe in time we stop actually doing band, and then we still do some, but like we used to do a lot more, versus now we are doing a very limited number of bands, because now we know that sleeve and bypass, these are the two that actually work the best for long term. So because when someone who has the gastric band, and then now chances of them actually repeating what they did, if they don't make good changes, it doesn't actually maybe support the procedure, the person as much as the other procedures are doing, because other procedures are, there's a structural change that actually requires the body to react in a different way, versus on the band, there is not much changes other than just taking the problem to a smaller area, but that smaller area is going to get bigger in time. So that's kind of like how I'm understanding every time we talk about this. So now the problem with this patient is when someone...
Let me pick a little bit on that. Kemal, I do agree with what you said about the fact that the other procedures are much more impactful in the change that we make. Clearly, there are some patients who do extremely well with the gastric band as well. I took the fact that there are patients of ours that have had the gastric band done about 20 years ago, and they still have their gastric band, and they still are 100 pounds below their weight, so they've kept their weight off. But when you look at the number of those patients, they are a minority compared to the patients who have the sleeve, right? Now, when we're doing a lot of bands at that time, the only alternative to the gastric band was the gastric bypass. And for many people, the gastric bypass was just too invasive. That's why the band was not ready. But now we have the gastric sleeve as well, which is almost like an in-between procedure, right? Because it's not as invasive and as impactful in the changes that we make in the digestive tract as the gastric bypass, but it is hugely much more powerful than the band in terms of what the weight loss could be and maintenance of that weight loss. So that would be one reason. And so clearly, with having more alternatives now, the band is taking a backseat essentially, because the gastric sleeve can do what the band was designed to do much more powerfully, but with a better quality of life. Clearly, there are obviously more risks with the sleeve than there are with the band. The sleeve is a non-reversible procedure, whereas the band is reversible. So all those issues need to be clearly understood. But choosing a treatment is always a question of understanding the risks and benefits, right? So if we can find that there are way more benefits to a particular option, and much less risks, then the choice is more clear. And that is the discussion I would like to have with Janice about her choices, essentially.
So going back to the hemoglobin being low, usually when it's under 10, we take an action from our point. The anemia is a problem, of course. In some cases, we do require hematology clearance, versus in some cases, with working with our bariatrician, this patient actually can improve their hemoglobin with iron infusion and other iron supplements. But that's not going to make an impact on the surgery type. So we're going to talk about her a lot. So then I'm going to bring our next patient, Patrick. Patrick is a 30-year-old. His BMI is 50. Okay. So A1C, surprisingly, is 6. So not everyone with high BMI will have like high A1C, but his TSH actually is 7. And then hemoglobin is at 12, and he came to us undecided. Now, one thing that we used to have, there's more female patients coming to us, but in the last 6-7 months, I see a lot more male patients. So that's kind of like a changing trend. I don't know the reason, obviously, but when I was actually looking for patients, usually having difficulties with male patients because we wouldn't have too many. But this time I had a lot of them to pick from. So, but this is a 30-year-old young person with A1C6, TSH 7, and hemoglobin 12, and undecided with BMI 50.
Mm-hmm. So, body mass index of 50. Okay,
yeah.
That's a dangerously high weight. There is no question about it, right? That is going to have a huge impact on his health going forward. He's 30 now, he's a young guy, but before the age of 40, he will develop many other illnesses related to weight. And the weight is unlikely to stay even where it is. It's likely to go up even in time unless it's addressed. So for Patrick to look for weight loss surgery is absolutely, absolutely the right thing to do right now. Now, he is undecided, which is good, which gives us room to have more discussion about what may be the best option for him, right? But you did mention some significant health problems, right? Of course, the fact that his A1C is not high, which suggests that he's in the pre-diabetes range, but he's not diabetic yet, right? That's a good thing. But you mentioned that his TSH is high. When the TSH is high, it means that he is hypothyroid. In other words, his thyroid gland is not producing enough thyroid hormone. Now, this condition has to be addressed before surgery. And why is that important? Well, for two reasons. Number one of the contributing factors to obesity could be hypothyroidism, which means that a thyroid which is not functioning well can be a contributing factor to the obesity. So we have to address that. That's important. It is very likely, like the vast majority of cases, that the reason we have obesity in Patrick's case is excess calorie intake. There's no question about it, right? But we have a high TSH, we have to address that. The second reason it's important for us to address that is that the surgery itself, the anesthesia itself, could actually be dangerous if we perform it without correcting the imbalance in the thyroid hormone that he has. So as we do it in our program, the patient will be referred back to their primary care doctor. Maybe Patrick is already taking some thyroid supplements. Maybe they need to be increased. If he was not taking them before, he needs to start taking, and we'll follow his thyroid level. And we can do that concomitantly with the other preparation. And that's the beauty of having this preparation, is because at the same time as we are addressing the thyroid issue, actually Patrick will be getting nutritional counseling, nutritional evaluation, nutritional education to improve his eating habits as well, and preparing him for bariatric surgery. As to the choice for procedure, we want Patrick to have a powerful procedure, right? But he does not need to go all the way to gastric bypass. Again, there's no compelling reason for that. In fact, in my experience, Kemal, I found that guys do very, very well with the sleeve gastrectomy, very well, in terms of really a lot of weight loss and improvement in their health as well. So I do think that the gastric sleeve would be a good option for Patrick. And obviously, I will explain to him the indications for the procedure. I will explain the risks, the potential complications. This is very important for him to understand, not just of this procedure, but all of the procedures before we make a decision as to which procedure might be right. But this would be the issues that we will be looking into when we talk to Patrick.
Sure. So now, just to summarize, he needs to see on top of our regular clearance process, he's going to see endocrinology. So we are going to work with the endocrinology, but we also have our bariatrician on board. So that he's going to work with the bariatrician as well as he's getting his nutrition classes. That's going to also help.
Yes. So the endocrinology issue would be something that may or may not be needed, depending on where the patient is in their care with their primary care doctor, right? So if the primary care doctor has been addressing this issue, then perhaps the test has not been done for some time. If they're already taking medications, it may just be a question of adjusting those, and probably the primary care doctor can address that. But often also we do send patients to endocrinology as well for additional input.
All right. So ready for this is like an office hours for you now. So, third patient, Third patient is Karen.
Mhm.
So Karen is a young-looking 52-year-old. Her BMI is 41.
Mhm.
Karen has heartburns,
Mhm.
and unfortunately, her A1C is 11. That
Mm.
means she has diabetes. Her TSH is 2, and hemoglobin is at 12.5. She came to us and she wants to get sleeve.
Sure. So absolutely. So important points to that are relevant for our case is the fact that A1C is 11. When the A1C, which is an indication of how bad the diabetes is, A1C is very high, 11. It's really too high, which means this is not only it's diabetes, of course, but it is poorly controlled diabetes, right? So the control is not there. Now, it may be that she has been maximized in her treatment, right? That she's getting all the treatments available right now and her blood sugar just is not budging. That's really poorly controlled, right? Or it may be that the current care, either because of follow-up or for whatever reason, is not being optimized, right? The other thing that is important that you mentioned is that she has heartburn. Now, again, we have to understand how severe the heartburn is. If Karen is taking 2 types of anti-acid medication because her heartburn is severe, right? She's having episodes of choking at night because of the heartburn severity. And then we will go ahead and evaluate her food pipe with endoscopy. We do EGD in our patients, and we find that there is severe irritation of her food pipe. Then in that case, not only do we want to give her a procedure that is going to be powerful enough to get her to lose weight, but also a powerful that will protect her from acid in the stomach. And that procedure will be the gastric bypass, right? So again, is there a contraindication in doing the sleeve, which is the procedure that she wants? Unless there is damage to the food pipe already, Karen still can have the sleeve even if she has a history of heartburn. She can still have the sleeve even if she has diabetes, because remember, Kamal, the sleeve is also a powerful procedure to get improvement in diabetes also, or resolution in diabetes. It's not as powerful as gastric bypass, but it's still very powerful. So the key and decisive factor as to whether we will go ahead with the sleeve or not will be when we do endoscopy and what we find at endoscopy. So that's going to be important. But on the face of it, if Karen had come to us with no choices, no, in a neutral type of fashion, then we probably would counsel her that gastric bypass might be the better option for her. One, because we want to have a big impact on her blood sugar control, and two, because obviously the heartburn is an issue that we want to address as well.
And also at her age, she's over 50. So if she was maybe younger, maybe we could maybe go with sleep, because then later on she can always make that change. But she's already over 50.
Absolutely, absolutely. And that's an important issue, obviously, because with gastric bypass, as we've talked before, the rerouting of the intestine has a number of implications. And one of them is, of course, the fact that we are taking the food away from the most active area of the intestine that really absorbs the food, which means that on the one hand, it's a good thing because they're not going to absorb the calories, but on the other hand, they are also going to have difficulty in absorbing essential nutrients like vitamins and minerals and so forth. So there is a risk of malnutrition long term. And then, of course, rerouting the intestine means also the intestine can twist and cause bowel blockage that may require surgery. And then the other and important factor is also when we connect the intestine to the stomach, that connection that we call gastrojejunal anastomosis, that can produce ulcers, particularly if a person is a smoker. So stopping smoking is very, very important. And obviously, I would be very interested to know whether Karen is a smoker or not.
She's not, actually.
She's not, and that's great. And then obviously taking medications that are called non-steroidal anti-inflammatory medications, NSAIDs, medications like aspirin, Aleve, Motrin, Excedrin, those will also not be allowed after gastric bypass because that connection can cause ulceration, and ulcers obviously can create complications.
So interestingly, our two female patients, one, they both have diabetes. Their BMI is close, yet we actually are going with a different procedure because the heartburn is an important factor.
Yeah.
And also the age of the patient is another factor for us, so that like we're trying to do the best, what's best for the patient. So hopefully, the way that these episodes are working, in some cases when we start the process, even if they already they are still they still want to go through the same procedure after the first consult. Once they watch these videos, we have many patients who change their mind in a way that they are now actually.
Absolutely. So Kemal, this discussion is very important. Clearly, Denise, Patrick, or Karen, okay, so far we have not seen any absolute contraindication to one procedure versus the other. So if they were insisting that they're much more comfortable with a particular procedure, we would be okay. The only choice that I think would not be good for any one of them would be to do nothing, right? Because that, and unfortunately, for every 1,000 patients, right, that would be eligible for surgery, only 10 are coming asking for help from us, right? If you think about it, right?
1%, right?
Right, absolutely. So which means that so many patients, right? If we could do any of those procedures on more patients, we would be doing a lot more good, obviously. So those procedures, all of them to some extent are very, very good procedures, right? So clearly, any procedure would be fine. And the only option that I would discourage them from taking would be to do nothing at this stage, right? Because all of them have serious health problems related to their weight, right? But our job, obviously, is to inform them, to give them the best possible option that may be optimal for their individual situation. And that is really the reason for today's Bariatric Friday discussion, right?
Absolutely, Dr. Ergau. This is always helpful, and as we are going to have, I think, like 16 or 17 episodes in this cycle, so we'll address different issues, different part of the process that patients are going through. And I think the start of the type of surgery is the main, one of the main milestone for the patients. Well, actually, for them to be even in our office first time is a big decision. Once they are there, we are here to hold their hands and then just walk them through this process. This is a serious decision, and we take this extremely seriously, obviously. And with the expertise that we have in bariatric, not just in Delaware, but in United States, this is one of the most expertise surgeons altogether in terms of our facility focusing on the bariatric. So we are probably one of the best, and I may be a little bit biased, but that's okay. So, but I know from our patient surveys that we are close to 100%. So that's not easy when we deal with a group of patients who have so many different problems at the same time, and they are taking a big decision in their life. And we want to be able to help more people. And we are going to go through this journey with Karen, Denise, and Patrick. And then they will be with us for the next 3 months, probably.
Absolutely. So essentially, Kemal, this is very, very useful discussion. But as we always say, it's a general discussion, right? It's not an individual patient counseling. The best time for us to actually give and provide treatment would be when we have an individual discussion where not only we talk about what's the best procedure, but we will talk also about the potential complications of surgery, because surgery has been made really safe, as I said at the introduction, but complications can still happen, and people need to understand the complications, and the context for that would be for them to really look at the benefits and risks of the treatment, for them to be comfortable to choose the treatment that is appropriate for them.
Absolutely. Well, Dr. Irgau, thank you so much for joining us. This was a great episode, and
Absolutely.
we'll be back next week and not have more updates. Thank you again. Have a nice weekend.
Thank you. Bye-bye now.